Okay, so this is the second part of the lecture. I just had them separated out. So we'll continue with cellular injury. This is just pretty basic. Illumination injury obviously is related to like UV light or different light forms, essentially. Things like eye strain, obscured vision, or cataract formation. A lot of these can be related to light, essentially, too. Mechanical stresses, this may be things like a physical impact, irritation, overexertion, and we'll kind of talk about this as we move into musculoskeletal injuries. Noise, obviously, you can have acoustic trauma, hearing loss, factors like that. Other cellular injury mechanisms could be related to accumulations or infiltrations into the cell. Obviously, water is a huge one that you'll commonly see with different disease states. So essentially, there's that shift of extracellular fluid or water that's going into the cells. This is a reversible injury or reversible cause, essentially. But it's very common to have, edema or shift of fluid into different cells under different disease processes. Lipids and carbohydrates, this can often be caused by metabolic disorders. You may see this with things like Tay-Sachs. Fatty liver is a big one that you'll commonly see a lot in primary care. And a lot of it can be related to like alcohol use or a high fat content in their diet, but they can get fatty infiltrates essentially into the liver. Glycogen, so you can have a glycogen storage disease, or another example, which is very common, is diabetes. Proteins, when we get into like, when we talk about the kidneys or urologic disorders, or you commonly see different disease states with the kidneys that you can see protein in the urine. But a lot of times if there's damage in the kidneys, sometimes you'll have protein excreted in the urine. So sometimes you'll see this with renal disorders or even multiple myeloma. But once again, we'll talk about that as we move through. This is just an image talking about cellular injury. The example at the top on the left is discussing hypoxia, and kind of like I mentioned at the beginning, it can alter ATP production, and then they get that shift in fluid where sodium water goes out of the cell, potassium into the cell. But essentially, they can fill with fluid, or it distorts the organelles within the cell essentially with that. Other forms of infiltrations like pigments, like even if you just think about melanin, obviously it can be deposited in the skin, and we call those nevi, which are essentially moles. Or you could have a decrease in melanin, and that's usually like albinism. Another thing too is it's obviously in your epithelial cells, but it also is by the eyes too, and it's actually a protective factor for UV light. Another thing that you can see infiltrates with is hemoproteins. A good example would be like hemochromatosis, and a lot of times these patients with hemochromatosis don't get rid of excess iron, so they actually store iron. But the problem is that it gets stored in your organs and your joints and your bones, and they're at risk for other disease processes because of it. But essentially with this, they can have infiltrates of iron essentially in organs. Bilirubin, I'm sure everybody's heard of bilirubin, and obviously, seen cases probably where there's excess bilirubin where they have jaundice or the patient does. So obviously you can have, infiltrates with bilirubin essentially, whether it's the brain or into the tissues. Calcium is another one. You will see this with injured tissues or dead tissues. There'll be calcium accumulation in that area. Another thing too is like we even look at calcium levels and stuff with coronary heart disease. Another one is urate, which is basically uric acid, which is an end product of purine metabolism. But urate, obviously, with uric acid, they're at risk for gout. So gout, once again, they start to get that, affects musculoskeletal issues. They can get it in the joint, or gouty arthritis with it. Or sometimes you'll see it in the kidney with kidney stones. But once again, that's just an example of like an infiltration. So when we talk about cellular death, essentially, there's obviously different causes, but when we look at the actual type of death, it's usually related to like, or it either goes into the route of necrosis or what we call apoptosis. Apoptosis is basically normal cellular death. It's almost like a programmed cell death. So it's kind of an organized manner of cell death. Sometimes you'll hear terms cell suicide, or necrosis is called cell homicide. So necrosis is much more unorganized, and there's a lot of inflammation with it, and you'll see a lot of tissue swelling. So sometimes even that normal healthy tissue around the necrotic area can have inflammation or swelling with it, where apoptosis is more programmed, and it's more to really get rid of those abnormal cells that we need to be getting rid of. So a lot of times there's not like an inflammatory process with it. But necrosis, obviously can happen with cellular injury. So there's basically different types of tissue necrosis that I want to go through real quick with you guys. So once again, necrosis is more of that inflammatory process. It's the other thing too is necrosis is usually always related to a pathologic cause, where apoptosis can be related to a pathologic cause or a physiologic cause too. But necrosis is always abnormal. Coagulative necrosis is very common in organs or cells that are caused from lack of oxygen or hypoxia. It can occur with chemical injuries as well. But it's more commonly seen like in the heart. That's probably the number one area. The kidneys you'll see it in, the adrenal glands you'll see it in. And once again, it's usually related to hypoxemia. You get protein denaturation. So basically it causes the protein, which is albumin is a protein, but it causes it to change from a gelatinous transparent state to like a more firm opaque state. So a lot of times too with this, they'll get abnormalities with intracellular calcium, and it's kind of a precipitant in this whole event. This is an example of the heart where you would see coagulative necrosis. So it's just basically necrosis in the tissue, very common in the heart, and once again, it's usually related to lack of oxygen. Liquefactive necrosis is more common in the brain. You'll see this very common after a stroke or an infection in the brain. It's usually ischemic injury to neurons and glial cells of the brain. But what happens is there's hydrolytic enzymes and lipids of the brain are basically affected because there's not a lot of connective tissue in the brain. So they start to essentially digest the tissue there. So that tissue gets really, really soft and it also becomes liquid. However, it is kind of walled off and it's kind of sectioned off by like a cyst-like wall essentially around it. Like I said, you'll commonly see this after like a severe stroke. You'll see it after, an infection in the brain. You may also see it with, like I mentioned, with different bacteria, whether it's staph, strep, E. coli. Sometimes you'll see it with different infections. This is just an example. On the right side, there's a CT scan. And if you look on the upper right where it's dark or, the shaded darker area, this is an example of liquefactive necrosis. So it's most common after like a severe stroke to that area where there's reduced blood flow. So once again, you can kind of see it up in this image too. So very common in the brain. Where caseous necrosis is another type, and this is very common with TB. So you'll see this a lot in the lungs. And it's actually a combination of coagulative and liquefactive necrosis. So essentially, there's a lot of debris there, but it's not digested completely. So they kind of get like a granular, soft type area. Like you'll see it on an x-ray that's kind of in a clump cheese type fashion. It's almost kind of like lumped together. And once again, there's like a wall that closes it off, like kind of like caseous necrosis where it's sectioned off into one area. But it's very common with TB. So this is just like a histology slide at the cellular level. But once again, like on the right, there's an x-ray. And it's hard to tell on this x-ray, obviously, but you can see that darkened area. And you'll kind of see the defined lines around it where you'll see like a walled off type cyst-like edge, essentially, with it. But it's common with TB. Fat necrosis is another one that you'll see. I've seen it, unfortunately, like with breast cancer, like severe late-stage breast cancer. You can see it with very severe pancreatitis and other abdominal organs, but I would say the pancreas and breast are very common. With the pancreas, there's a lot of digestive enzymes, obviously, and it causes cellular death in that area. But it can break down the triglycerides, and it basically releases fatty acids, but combined with calcium, magnesium, the ions, and they actually create like what they call a soap. And a lot of times, like if you were to see it on a scan, if it's internal, like in the abdomen, it's more opaque and chalk white, essentially, with that. But fat necrosis is very common, more with breast and pancreas, essentially. And then next, obviously, there's gangrenous necrosis. I'm sure everybody's seen this at some point or another. It's death of tissue that's from severe hypoxia. commonly caused from vascular disease, blockage of major arteries. So once again, it's just related to lack of blood flow to the area. You'll see this commonly in those patients that have severe diabetes, that have severe, vascular disease alongside with it. It's very common in the legs. You'll see usually, tissue death essentially in the feet or the toes that you'll commonly see it with. It can be dry or wet, so we kind of describe it in two different processes. With dry, obviously, it's more dry, and it kind of shrinks up and wrinkles up, essentially. But they do have those skin color changes where it goes from that dark brown to blackish color, but it's more dry. And then, obviously, you can have wet, too. So there's basically more of that liquefactive necrosis that occurs there. A lot of neutrophils, which is a portion of your immune system, kind of invade that site, and then they start to get pus there, a lot of discharge there. They do get black, but there's a lot of swelling too involved because of the immune response with it. And secondary infections are really problematic with this as well. This is just an example of gangrenous necrosis. This would be an example of the dry. Once again, like I kind of talked about, we have necrosis and apoptosis. So apoptosis is more normal. It can be normal and pathologic, but it's more of a programmed cellular death. It affects single cells, so it's not like a mass area. It's more organized. A lot of times they don't have that tissue swelling like they would have with necrosis. There's not a lot of inflammation. There's not a lot of immune cells that go to that area. So essentially we kind of call it the cell suicide versus, a necrosis essentially. In terms of aging and altered cellular biology, obviously aging versus disease, there's different defining characteristics there. Aging over time is obviously where you have loss of structure and function, and it's very slow. So obviously there are such small increments that you really don't, see it on a day-to-day basis. It's basically an accumulation of very small injuries, like that wear and tear that occurs. And obviously disease can contribute to, the rate of aging, I guess I should say. So, you compound, normal aging with disease, and it's obviously it can affect the lifespan of the patient. So disease is obviously the result of injury. In general, the normal lifespan is 80 to 100. Women tend to live longer than men. However, when we get to the next slide, women tend to have more issues with being frail, like a frail older adult, and we'll talk about that too. But disparities in life expectancies have a lot to do with like genetics, the environment, which we'll talk about when we go through epigenetics. Because a lot of that interplays together, whether, it's stuff in the environment or exposures and genetic factors that are kind of linked with it as well. So obviously it can affect life expectancy as well. There's different theories of aging. You can go ahead and take a look at this. But once again, there's a lot of genetic and environmental factors that interplay here. In terms of cellular aging, these are, like progressive stiffness and rigidity. A good example is why, patients develop hypertension as they get older, essential hypertension. Even our arteries and all that, they are not, they become more stiff essentially, and they're more prone to developing hypertension essentially. Sarcopenia basically means that they have muscle wasting, or so their muscles may atrophy a little bit with it. So a lot of times too with, aging, a lot of our physiologic processes decline and they're not as efficient as they are when you were really young. An example too, like, we always look at kidney functions in patients because it's important when we're treating patients with medications. You have to look at factors like that too. Frail older adults is another topic too that we'll discuss a little bit more. But with aging, it's more of a syndrome that you'll commonly see with that older adult where they have a lot of issues with mobility. They have a lot of decrease in muscle strength. And a lot of times like their nutrition might not be great or they have poor bone density. So it's kind of a combination of multiple factors, but it puts them at significant risk for functional decline. These patients are at high risk for falls, or if they have a fall, they don't recover very well. They have a high risk for chronic disease, or they already have an onset of chronic disease, but they have high risk for mortality and morbidity, essentially. But it's not uncommon to see this, and these are those patients that tend to be hospitalized a lot. So you've probably encountered this within clinical practice already. In terms of somatic death, that's essentially death of the entire person. You can go ahead and take a look at this and read this. And if you have questions, just let me know. So next I'm going to do a lecture on epigenetics and some of those environmental factors that we'll take a look at as well. So I will have that up, and if you have any questions, obviously, please feel free to reach out to me, and I'm more than happy to help. So I will talk to you soon. Thank you. Have a great day.